Welcome to the pediatrics class. Dear doctors, this is 𝗲𝗵𝗵𝗺 class and I welcome you in the newborn examination where today we'll be discussing about the chest abnormalities, the neck abnormalities, abdominogenital abnormalities and extremities, if any pathologies associated with the extremities. So neck, chest, abdominal, genital and extremities will be examined in this video, and of course then you will be understanding that what are the problems you have to look for while examining these parts. First of all, coming on to the neck region. So in the neck, please understand the first abnormality is torticollis, and torticollis occurs because of the result of trauma to the sternocleidomastoid muscle during birth. So for example, if I do this action, the sternocleidomastoid is getting prominent, but if sternocleidomastoid is gone, I can't do that action which I was doing before. Of course, the chin is lifting up and tilting to the other side. This can't be done. So this is called as torticollis. Similarly, on the anterior border of the sternocleidomastoid muscle, there can be a branchial cleft which can be there. Okay. So on the anterior border of the sternocleidomastoid muscle, there can be a formation of cleft formation. So can you see, this is the muscle and this is the cleft formation which has happened on the anterior margin of the sternocleidomastoid. This is the second most important neck abnormality. So first one was torticollis, then the branchial cleft. After that, you have got cystic hygroma. What is cystic hygroma? So what happens, my dear friends, that sometimes in pediatrics, sometimes in infants, the lymphatics are not formed properly. So because the lymphatics are not formed properly, there is a swelling which develops in this part, and this swelling is called as cystic hygroma because it's a cyst-like swelling that is occurring because of the lymphatic malformation. So because of the lymphatic malformation, there is a cystic hygroma which is going to occur. So lymphatic, C and C for cystic hygroma, that's going to happen. And of course, the T and S are very close alphabets in alphabetical series. So of course, sternocleidomastoid muscle having torticollis, and branchial cyst is branchial for a reason. Branchial means it is there in the neck region only. So we have to examine the neck, and neck is also examined for the excess skin. For example, this is the face and this is the neck region. If there is excessive skin which is there, the neck is just looks like a webbed neck, and this webbed neck is seen most commonly in a Turner syndrome. So whenever you have Turner syndrome child, there will be webbed neck which will be there. Okay. And what is the genotype of Turner syndrome? It is 45XO. Okay. Coming on to the chest. Now the chest can be asymmetrical. Why? Because of the absence of pectoralis major muscle. Are you getting it? So the chest can be asymmetrical because of the absence of pectoralis major muscle. So one side pectoralis major is going to be there, other side the pectoralis major is not going to be there. So this asymmetry might be because of the pectoralis major muscle, and P for pectoralis major muscle, P for Poland syndrome. P for pectoralis major muscle, P for Poland syndrome is there, in which one side of pectoralis muscle is absent. That's why one side is taut, one side is lagging. That leads to chest asymmetry. Similarly, pectus excavatum and pectus carinatum are two different conditions which are there on your chest. So can you see, this is a protruding chest. This protruding chest is pectus carinatum. Carinatum means carrying something extra. So carrying something extra, this is carinatum, whereas excavatum is excavated. Something has been excavated, something has been taken out. So pectus excavatum means sunken chest, carinatum means protruding chest. Both of them can be the manifestations of rickets. What else? The other thing is the breast. So the breast should be examined for nipple spacing. If the nipples are widely placed, this is a feature of Turner syndrome. This is a feature of Klinefelter syndrome. Mostly Turner has got a widely spaced nipple. In some conditions, there are accessory nipples also, which are going to be present, of course, in the milk line. And what is this milk line? This is a imaginary line which is going to be there from the axilla to the pubis, from the axilla to the pubis. From the axilla to the pubis can have accessory nipples also, okay, from the axilla to the pubis. So all these things you have to check whenever you are checking for the chest. Coming on to abdomen. So my dear friends, in abdomen you have to check for umbilical hernias. Alright, so something protruding, some intestinal abdominal mass protruding out of the umbilicus is called as umbilical hernia. Whereas abdominal wall can have other two more important things. One is called as Omphalocele, the other is called as 𝗲𝗲𝗵𝗵𝗺. Okay, so one is Omphalocele, other is 𝗲𝗲𝗵𝗵𝗺. So what happens in both of these, Omphalocele and 𝗲𝗲𝗵𝗵𝗺, the content, the abdominal contents are going to protrude in both Omphalocele and 𝗲𝗲𝗵𝗵𝗺. But what happens is, in Omphalocele, there is a peritoneal cover which is going to be there because it is protruding, yes, and inside of course there will be content, but it is covered by a pouch. So omphalo is a pouch actually. Phallo, whenever the word phallo comes, it is actually pouch. So omphalocele, that means there is a pouch which is going to cover the abdominal content. So omphalocele is covered by a pouch, whereas 𝗲𝗲𝗵𝗵𝗺 has no pouch. Other thing is, omphalocele is umbilical. Omphalocele is umbilical, 𝗲𝗲𝗵𝗵𝗺 is para-umbilical in location. Omphalocele is umbilical, 𝗲𝗲𝗵𝗵𝗺 is para-umbilical. Omphalocele, why omphalocele is occurring? Actually, see, what happens is that in the fetal life earlier, the space available in the abdominal cavity is very less, and what happens, as the content starts to grow, content comes out. But as the fetus enlarges, the abdominal cavity enlarges, the content regresses back. Simple. So what happens in omphalocele? The content fails to return into the abdominal cavity. That's why it is protruding. So what you have to remember? Remember, cut is the mnemonic for omphalocele. C for content fails to return back to the cavity. U for it is umbilical in position, and T for trisomies, because omphalocele is associated with trisomy 13, 21, 18. So 18, E for 18, E for Edwards, very simple. E for 18, E for Edwards, simple. 21 is Downs and 13 is Pataus. For those of you who understand Hindi, I have a mnemonic that 13 in Hindi is called as Tera, and 𝗲𝗲 Patau, 𝗏𝗏𝗏 is just like the mnemonic. In English, I can say that 13 in Hindi is called as Tera and 𝗲𝗲 Patau. What I mean by this is, may I please ask you for a relationship, okay? 𝗲𝗲 Patau. So 13 is the Patau syndrome, okay? But 𝗲𝗲𝗵𝗵𝗺, in 𝗲𝗲𝗵𝗵𝗺, the content is going out, the content is coming, but the abdominal wall is not able to fuse. Of course, the content is out, the content is going to come, so abdominal wall should fuse, na? It is failure of fusion. So abdominal wall fails to close, that is the 𝗲𝗲𝗵𝗵𝗺. Okay, so these are the things which you have to look while looking at the abdomen. Coming on to diastasis recti. So you know that you have got rectus muscle. Rectus muscle is there. Rectus abdominis. What is the function of rectus abdominis? It is going to keep the abdomen straight, rectus straight. So what happens? Sometimes the left and the right side of the rectus abdominis are separated. That's why this is a straight part, this is a straight part, but here there will be a bulge because there is a separation in between. This is called as diastasis recti. Di means two, so the two halves of the recti are away from each other. Diastasis recti. After that, you have got persistent urachus. So what is urachus? See what happens in the neonatal life. This is the urinary bladder, this is the umbilicus. So in the fetal life, there is a connection between the urinary bladder and the umbilicus. This is the connection. Now for example, if it is getting persistent even after the child is born, of course the urine is going to leak from this opening, and this opening is called as fistula formation. This opening is called as fistula formation. So persistent urachus, actually what is urachus? Urachus is the connection between the urinary bladder and the umbilicus. So if it is persistent urachus, it results in fistula formation. Of course, there will be a fistula between the bladder and the umbilicus that causes urine to dribble out of the umbilicus. Coming on to meconium plug. Now what is meconium plug? For example, this is the colon which I have tried to show you. This is the right side of the colon, this is the left side of the colon, and for example, meconium is getting lodged in the left side of the colon. It causes what? See, here is a meconium. So the ileum is going to dilate. There is a dilatation of the ileum and this is called as meconium ileus. Okay. What is meconium? Meconium is actually the first stool which is passed by the baby. So what is meconium plug? Plug means it is obstructing the left colon and the rectum. Why? Because it is getting dense, it is getting lodged there. That leads to occlusion of the distal ileum and that leads to dilatation, that is called as meconium ileus. Now why it is getting lodged there? Because it is getting dense, it is getting bulky. Why it is getting bulky? Because of increased secretion such as seen in cystic fibrosis. Cystic fibrosis is a condition where there are a lot of secretions which are going to come. Of course, the lot of secretions, the meconium is going to get bulky and it is going to get lodged here, and once it is getting lodged here, that leads to dilatation of the ileum, meconium ileus. And of course, when you are examining the abdomen, you should check for the umbilical cord also. What will you check in umbilical cord? The umbilical cord should be inspected to see the Wharton's jelly and of course the umbilical vessels. So what happens? See, normally in umbilical cord, this is the Wharton's jelly. The black one is the Wharton's jelly. There will be two arteries which I have drawn with pink color, and there is one vein that is going to be in the blue color. So all these structures should be patent. In the recent central exam, this was asked that how many arteries are going to be there. So remember, two arteries and one vein is going to be there, because you can remember one vein, very similar pronouncing, one vein, one wing. Okay, so vein is 1 and artery is 2. So you have to keep a check of it. Coming on to female genitalia. So remember, clitoris is a normal finding in a female, but if the clitoris is enlarged or hypertrophied, this is because there are increase in amount of male hormone production in females, and the condition is called as virilization. Okay, so hypertrophied clitoris, or sometimes called as clitoromegaly, is because of increase in amount of male hormone production in the female, that is called as virilization. Next is hydro, increased fluid, metacolpos, that means uterus. So uterus might have increased amount of fluid. Why? Because the hymen, which is the hymen is present near the vagina, and if hymen is not torn, if it is imperforate, of course in the puberty, post puberty or near the puberty, there will be hydrometacolpos that is going to happen, imperforate hymen. Okay, and even if you if you call for the female genitalia, please understand, sometimes vaginal bleeding from the baby is actually normal. Okay, at the birth the child might show vaginal bleeding. That's absolutely a normal finding. Why does it happen? Because of the maternal hormones. So maternal hormones are going to go to the child and these might cause vaginal bleeding. That's a normal finding in a female infant. Coming on to male genitalia. So male genitalia, you should check for the scrotum, and scrotum should be having the testes and both of them equal in size. If there is no testes there, of course the condition is called as cryptorchidism, that's going to be present. Cryptorchidism, that means the testis has not reached the scrotal sac. The testis might be in the inguinal region or somewhere else, but remember, that's not the site of the testis to grow, and if the testis is growing anywhere else then the scrotum, this is a disposing factor, predisposing factor to malignancy. It can cause malignancy. Coming on to hypospadiasis. What is hypo? Hypo means below. So hypospadiasis means, see, normally this is the location for urinary meatus. But if it is below means on the ventral aspect of the penile shaft, or I should say the penis, this is called as 𝗲𝗵𝗵𝗺. Alright, and of course this is associated with urinary malformations. What is 𝗵𝗵𝗵𝗺 then? 𝗵𝗵𝗵𝗺 means it is above. Hypo means below, 𝗵𝗵𝗵𝗺 means above. And this above 𝗵𝗵𝗵𝗺 is very commonly seen with a condition which is called as bladder extrophy or ectopic vesicae. Bladder extrophy or ectopic vesicae. What does that mean? That the bladder is coming out. Okay, so the urinary opening, the meatal opening, is also on the dorsal aspect of the penile shaft or dorsal aspect of the penis. These are seen in a very close combination. There is nothing to find the logic about it. It is an observation. So I am telling you that 𝗵𝗵𝗵𝗺 is commonly seen with bladder extrophy or ectopic vesicae. So can you see, this is the bladder which is coming outside the abdominal wall. Coming on to the extremities. So extremities, of course, the hand and the feet are very important. So one abnormality is syndactyly. Syn means fused, dactyly means digits. So syndactyly means fused digits. And D for digits, D for nouns. So fused digits are characteristically seen in the Down syndrome, whereas it is also seen in the Apert syndrome, Poland syndrome, Holt-Oram syndrome, Carpenter syndrome. Apert syndrome, Poland syndrome, Holt-Oram syndrome, Carpenter syndrome. Mnemonic becomes 𝗏𝗏. 𝗏𝗏. What does the 𝗏𝗏 word mean? 𝗏𝗏 means boys. And as the girl says, boys just run behind the girls like anything, right? This is how the girl says. So running behind means trying to sticking to the girls. Boys always try to stick to the girls, right? Is it? Yes. So sticking means sticking. Sticking means syndactyly. So syndactyly, the mnemonic is 𝗏𝗏. What do you mean by polydactyly? Polydactyly means multiple fingers are going to be there. When it will be seen? Trisomy 13. Single palmar crease, very important. So see, I don't know if you can see my hand or not, but there is multiple creases which are there. In fact, you can see on your own hand also, multiple creases are there. But if you have only one crease, you are suffering from Down syndrome. So how do we remember? We say that the number of palmar creases are going to come down. Number of palmar creases are going to come down. So single palmar crease will be seen in Down syndrome. Next important part is the 𝗶𝗵𝗃 palsy. So 𝗶𝗵𝗃 palsy is C5-C6 root value injury that causes the upper arm is in adduction and internal rotation with the forearm, which is nothing else but the extended forearm. So very easy to remember, adducted, internally rotated upper arm, and the forearm is extended. This is 𝗶𝗵𝗃 palsy. That was C5-C6. Now coming on to C7 and T1. If C7 and T1 are involved, that causes Horner syndrome. Which syndrome? Horner syndrome. And the cheat code to remember the Horner syndrome is P meal, or you can say protein meal. Protein meal. Okay. So what does this protein meal abbreviation stands for? P for ptosis. Of course, they will be having drooping of eyelid. Meiosis. What is meiosis? Meiosis means the pupil is going to be constricted always, because there is a nerve which is going to supply the sphincter pupillae. That is also injured because of the C7 and T1 are injured. So pupil constricted, and ptosis is going to be there. That means the eyelid is drooping. So it seems that the eye is pushed inside. That is called as 𝗵𝗵𝗃. There will be anhidrosis. That means there will be no lacrimation, and there is loss of ciliospinal reflex. This is the mnemonic to learn all the features of Horner syndrome. Coming on to the hip part. So understand what happens with the hip. So there is something which is called as developmental dysplasia of the hip. There is something which is called as developmental dysplasia of the hip. So what happens if you want to dislocate the hip, which is actually congenitally dislocated only? If you want to dislocate the hip, my dear friends, you have to hold the legs of the child, adduct them and give a posterior pressure. You'll hear a voice. That means the hip is dislocated, the femur is out of the acetabulum. Hold the hip, adduct them, put the posterior pressure. That means the hip is out, the femur is out. So this is the way to check the developmental dysplasia. But of course you have to relocate also. Then what you have to do, the dislocated part, dislocated portion has to be relocated. How? You will have to abduct the hip and you have to elevate. Abduct, elevate, and then you will hear a voice. That means it has been relocated now. So this is the way. Hold, adduct, posterior pressure, out. Then hold, abduct, elevate. That means insert it, reinsert. So this is the way to assess the developmental dysplasia of the hip. Coming on to the region slightly above the hip, that is the spinal region. So what you have to see in the spinal region, there will be dimpling which will be there. Why there is dimpling? Because of spina bifida. Because of spina bifida. So bifida means, bifid means there are, bi means two, fida means heads. So there will be two heads of the spinal cord. That's why one head, second head, there will be dimpling. So you have to check for the dimpling in the hip region to check for the spina bifida. Okay. So this is all about the session of the examination. Thank you so much. God bless you.